Assalamu alaikum students. Today we are going to discuss the third one type of dehydration, that is mixed dehydration. As we discussed in other two types, that were primary dehydration and secondary dehydration. In primary dehydration, deficiency of water is there, pure water depletion is there. And in secondary dehydration, the actual deficiency was of electrolytes, sodium or salt. In case of mixed dehydration, both water and salt will be lost, and they will be lost on parallel rate. It means almost equal loss of water and salt will be observed, and this is the type that is most commonly observed in daily life practice, in which loss of salt and water both are observed. Now, what is the effect of mixed dehydration on volume of ECF, volume of ICF? Initially, extracellular fluid, that is ECF compartment fluid, will be hypotonic. Why it is hypotonic? Because when patient is suffering from mixed dehydration, the ECF will try to compensate its water loss from the ICF at the expense of ICF. When water from ICF enters in the ECF, what would happen? ECF volume will be increased. It means water deficiency has been fulfilled, has been recovered, but salt is the same. Salt loss has not been compensated. So less salt is present in more water now. That term is known as hypotonic, like dilute solution, less solute concentration in more solvent. Later on, what would happen? As mixed dehydration is continued and there is no water replenishing and no water intake or any clinical treatment is given, ECF will also ultimately becomes hypertonic because that water is being used in other metabolic activities in the body. So ultimately, when water will be lost from the ECF and no water is taken, ECF will become hypertonic. What are the clinical and biochemical features that are associated with the mixed dehydration? Obviously, there will be equal loss of pure water as well as salt. Now, the volumes of both fluid compartments, ECF and ICF, will be reduced. As we have discussed the reason how volume of ECF and ICF is reduced. At first, the water, in case of mixed dehydration, at first water will enter from ICF into ECF. But and in that case, intracellular dehydration will be there, thirst will be there. But initially, as we have discussed, ECF volume will be maintained. But as the time goes on and no treatment is taken, ECF volume will also be reduced. Complaint of thirst will be there because water deficiency is there. Pure water deficiency will cause thirst. Low blood pressure due to less blood volume, due to less plasma volume, due to less water in the extracellular fluid. Obviously, blood pressure will also be down. High blood urea. Blood urea is the waste product that is excreted by the kidney through the urine, and when there is less volume of water in the body, kidney will excrete less urine. So when excretory volume of urine is low, obviously excretion of waste products will also be reduced. So blood urea level will be high, and that will indicate kidney dysfunction in this condition. Decreased urinary output. This is obvious reason. When there will be less water in the body, when there will be deficient fluids, urinary output will be low. When urinary output will be low, obviously salt excretion will also be compromised and less salt will be excreted through the body. Now we see how these cases are treated: primary dehydration, secondary dehydration, and mixed dehydration. Primary dehydration, as this occurs due to the deficiency or depletion of pure water, it will be treated by oral intake of water. Hydration will be better, and mild to moderate cases are easily treated at home by only replenishing the water and any fluid that contains pure water. But clinically, if the case is severe, if the patient is hospitalized, if he or she is in emergency, what would done? What would be done? 5% glucose will be injected, either IV or SC. SC is subcutaneous under the skin. So what this 5% glucose will do? As glucose is source of energy, it will restore the energy level of lethargic patient. And but 5% glucose, as it is a solute, this solute will exert osmotic pressure and try to drag water and maintain the fluid volume in the ECF. But remember, never give isotonic saline solution to the primary dehydration patient, because deficiency is of pure water only, not the salt. So isotonic saline solution is going to increase the hypertonicity of the plasma. Hypertonicity means more abnormally high salt concentration. So as deficiency is of water, we will give the water to treat the case. So whenever the question is asked how primary dehydration is treated, you will just write down and you will just tell 5% glucose solution by IV or SC route. Treatment of secondary dehydration. Now we will again focus the cause that is causing secondary dehydration, and it is salt deficiency, it's electrolyte deficiency, and or it's sodium deficiency. So isotonic saline solution will be administered to the suffering patient. Isotonic means same concentration. So isotonic saline solution is normally used 0.9% NaCl. 0.9% sodium chloride is isotonic saline solution. Treatment of mixed dehydration. Mixed dehydration, as you know, there is loss of salt and water, so we will replenish both things. ORS, this is a very common solution that is used at home, at all the homes, and you might have noticed in your daily life practice that the patients, that the children, the adults or old age persons suffering from dehydration are given ORS solution, that is also known as Nimcol solution in common language. ORS stands for oral rehydration salt therapy. Oral rehydration salt therapy. And it contains what? It contains saline as well as glucose. You can prepare this solution at home as well. How ORS will be prepared? You can take 1 liter of water and add 20 grams of sugar, 4 grams of sodium chloride, 3 grams of sodium citrate, and 1.5 gram of potassium chloride. Now, how these chemicals will be added at home? You will take 1 liter water and you will add sugar, table sugar. You will add a pinch of salt according to the volume of the water. And if you are using 1 liter water, you will add almost 1 tablespoon, that is round about 4 to 5 grams. Now you will squeeze a lemon in this solution, that is the source of citric acid as well as potassium. So sodium citrate will be formed, potassium chloride will be formed, and NaCl you are directly adding, sugar you are directly adding. So it can be a good alternate of ORS solution. That is the lemonade you usually make in summers. So it's a very good blend to replenish the water and electrolyte losses. Osmotic imbalance and dehydration. This is a phenomena and disease that is cholera, and we will say and we will discuss how this disease is going to cause osmotic imbalance in the body. Cholera is it's a water or foodborne disease that is caused by a microorganism known as Vibrio cholera. Now, what this microorganism is going to do, it will produce a toxin that is known as cholera toxin. And this cholera toxin is going to stimulate the intestine. intestinal movements, and intestinal stimulations will cause what? It will be resulted in secretion of electrolytes into the lumen of intestine. And what are the main electrolytes that are being secreted? These are sodium, chloride, potassium, and bicarbonate. And they will be secreted into the lumen of intestine, into the cavity of intestine. Now, when high amount of solutes are present in the lumen, it will result in high osmotic pressure. Obviously, high amount of solutes will exert high osmotic pressure. So high osmotic pressure will result in dragging of water, and more water will be retained in the intestinal lumen. Now retention of water will result in loose diarrhea, as a result of which almost 5 to 10 liter of water is lost daily. So a loss of electrolytes is there, loss of water is there. That's why we are taking the example of cholera disease in mixed dehydration. If this condition is not treated properly and ORS is not given, it may lead to death as a result of excessive loss of electrolytes and water due to severe dehydration, and that will be an emergency case. The second one pathology of abnormal water metabolism is water intoxication or overhydration or edema. Up till now we discussed about all the conditions in which water was deficient. Now this is the reverse. Now this is the opposite case in which more water is present than normal. Abnormally high quantity of water is found. So it is represented by excess retention of water in the body, and when there will be excess retention, when there will be more amount, tissues will be fluid filled, leading to a condition edema. Now we will discuss one by one what are the underlying causes that are going to cause water intoxication or overhydration. First cause is abnormally high water intake, fluid intake. Obviously, when there will be excessive intake or administration of fluids, it will make diluted ECF. Obviously, blood plasma will be abnormally high, and it will be abnormally hypotonic, and more water will be present that will enter in the tissues as well. And osmotic pressure will be reduced because solute concentration is now less due to more fluid or solvent presence. Renal failure. How renal failure is associated with overhydration and water intoxication? If kidney is not functioning properly, and if there is any pathology regarding kidney tubules, if there is any stone, cyst, or any tubules defect, the urinary amount will not be normal. Less urine is being produced, that's why more water is reabsorbed in the body. That will lead to water intoxication. Another hormonal reason is hypersecretion of ADH. And you know what is ADH? ADH is anti-diuretic hormone that was being secreted from posterior pituitary gland, and that is going to reabsorb water. The main function of ADH is reabsorption of water. So if ADH is secreted at a abnormally high rate, what would happen? It will do its function very high, and that function is reabsorption of water. So more and more water will be reabsorbed, and it will be present in plasma, leading to water intoxication, overhydration, swellings, and edema. Anesthetic drugs, they are going to increase the water intoxication in the body because and similarly narcotic drugs and stress, all these factors are psychologically related, and they can also lead to increased amount of ADH, ultimately leading to overhydration. Excess of aldosterone. Aldosterone, you know, now we have discussed in last two lectures, it's a mineralocorticoid and it is secreted from adrenal cortex. If adrenal cortex dysfunction is there, it will secrete more aldosterone. And what is the function of aldosterone? Sodium reabsorption. So high amount of aldosterone will result in high sodium reabsorption. So high sodium reabsorption will retain more water. Sodium retains water. When there will be high sodium, it will retain more water. Why there is high sodium? Due to the excess of aldosterone. Why there is excess of aldosterone? Due to adrenal cortex dysfunction. So gland dysfunction will release high amount of hormone that will ultimately lead to sodium imbalance and excess sodium reabsorption in the body that will ultimately lead to water intoxication and water retention. Now, what are the biochemical features observed in case of water intoxication? These are headache, muscular weakness, delirium. Delirium is abnormal mental state, and incoordinated movements along with nausea. In next lecture, we will discuss about pH and pH related concepts. Thank you very much. And this lecture is taken from Chatterjee, and you will study Chatterjee and Satya.